Hit the subscribe button or visit us at auau.auanet.org.
Thank you so much. And what a wonderful whirlwind of information on radium and bone health. Thank you so much for going through that. Let's now talk a little bit about some other treatments for metastatic CRPC, thinking about immunotherapy and PARP inhibitors, and actually the way that our understanding of how to best use some of these agents is evolving over time and with ongoing data. All right, we are off to an incredible start. Here it is. So thank you to Dr. K, who helped update some of these slides about a year ago and made them better, of course. Here are my disclosures. And here's our outline. We will be talking about that evolving treatment landscape, as I mentioned, going through new approvals with PARP inhibitors as single agents, and then some updated data with PARP inhibitors that are used in combination. We'll talk a little bit about immunotherapy options, and then how we identify patients for some of these targeted treatments in ways that are rational and really, hopefully, easily incorporated into our clinical practices. So to start with the evolving treatment landscape, I would say that it's obviously becoming increasingly complex. This talk is meant for 20 minutes, but could certainly span much longer than that, and I will keep it to my timeline. But it is important to know that we have so many options now. And what I think is really important to emphasize on this slide is that the options for metastatic castration-resistant prostate cancer evolve with each line of therapy that we give. And this slide really only represents how we think through first-line metastatic CRPC treatment. Obviously, we want to get through as many lines as we possibly can for any individual patient. And what this slide emphasizes is that we need to think about patients in terms of where they've been to really anticipate and to decide where they should go in terms of future therapies. So for example, in the upper left, patients who have not had docetaxel intensified therapy in the metastatic hormone sensitive setting or any intensified androgen receptor treatment, in addition to their ADT, can get any of the options listed there in the upper left. Most of our patients coming into the first-line metastatic castration-resistant prostate cancer setting should have already had, at a minimum, ADT plus an androgen receptor targeted agent. Whether they had that in the metastatic hormone sensitive setting or whether they had that in the non-metastatic CRPC setting is up to the progression of their disease to decide. But most patients should have had some sort of intensified treatment in the prior lines if we are doing our jobs properly. That means that patients should probably be up in the upper right box on this slide, where patients have had a prior novel hormonal therapy, maybe not docetaxel. If they've had both that novel AR-targeted therapy and docetaxel, then they're going to be in the bottom right. But let's try to make sure we intensify early so that when we get to metastatic CRPC, we're able to make those choices and continue to move patients through their treatment journey. This is another way that I think about it, and color coding really helps me to really understand different mechanisms of action and think about how we move from line to line. Essentially, we want to change the color, which is representing, again, mechanism of action as we move from line of therapy to line of therapy. And really that change in mechanism of action is what's going to ensure that a patient's going to hopefully have the best chance of having their disease respond to that next line of therapy. So remember where they've been, change the line when we change line of treatment, we want to try to emphasize changing mechanism of action, particularly if a patient's had an AR-targeted agent. We want to move to something that is not targeting the androgen receptor directly. All right, so why is that so important? Because these little cancer cells are sharing mechanisms of resistance amongst each other. And this study really demonstrated that. It shows, which is actually quite scary. It shows that when we take biopsy specimens from these patients who had multiple areas of metastatic disease and look at the genetics of each of these areas, you can actually trace mechanisms of resistance and trace the way that these were shared from metastatic site to metastatic site and with the primary. And so really, again, shifting mechanism of action is going to be critical in ensuring our patients have the best opportunity to have a response of their cancer to your next line of treatment. So to focus now on PARP inhibitors, which are probably a novel mechanism of action in the metastatic CRPC setting. This is really something that we have found is important for some of our patients who do have these HRR mutations that are present either in germline or in somatic tissue. Importantly, in metastatic castration-resistant prostate cancer, over 20% of patients are going to have these DNA repair alterations present in their either germline or somatic material. The frequency of these DNA repair alterations does increase with disease progression because, of course, we're selecting for patients with more aggressive disease with each line of progression. Importantly, too, when we look at all patients who have metastatic prostate cancer, almost 12% of those patients are going to have germline genetic alterations that fall into this HRR mutation category. And so it's recommended, as I think we've already talked about, for all patients with metastatic prostate cancer to have germline genetic testing, both to inform their potential future treatment options, but also to inform family testing. It is also important to note that patients who carry a BRCA2 mutation in their germline have a worse prognosis, whether we're looking at localized disease or we're looking at advanced disease. So really ensuring that we get the best treatment to those patients as early as possible is critical. Now, PROfound was a really important phase 3 trial that led to the approval of olaparib for metastatic castration-resistant prostate cancer. These patients were selected as having HRR mutations in germline or somatic tissue at the time of entry into this trial. All patients had mCRPC and had progression of disease on an AR-targeted agent and chemotherapy. And many had had exposure to chemotherapy, but some were not chemo fit. Importantly, patients were randomized 2-to-1 to receive olaparib or the alternate AR-targeted agent, as you can see here in this schema. So if they'd had exposure to abiraterone, they were randomized to enzalutamide or vice versa. And they were followed for a primary endpoint of progression-free survival. Here we can see the primary endpoint demonstrating that the red lines actually show a better progression-free survival associated with olaparib when compared to the orange circles, which represent treatment with the physician's choice of the alternate AR-targeted agent. And this was a median rPFS of 7.3 months versus 3.5 months, really showing a hazard ratio here of 0.34, which is highly statistically significant. That was in patients who had BRCA1, BRCA2, and ATM mutations. And here we can see it actually shown a little bit more clearly. I think that last slide, the lines were a little bit messed up. So again, this is in the cohort who had BRCA1, BRCA2, or ATM, cohort A in this study. Here we can see the overall survival for the overall cohort here, which includes patients who not only had BRCA1, BRCA2, or ATM, but also patients who had one of a number of different HRR mutations that could have been included in this trial. And here we can see that there's an improvement in overall survival associated with treatment with olaparib as compared to the alternate AR-targeted agent, even though there's crossover in about 66% of these patients who actually got olaparib even though they were initially in the control arm. That overall survival benefit in the overall population demonstrated here. And what's really important as we think through, do we actually want to treat all patients with the HRR mutations identified and included in the PROfound study, or do we really want to target certain mutations, is that there have been some exploratory analyses, both in the PROfound trial, which is on the right here, as well as in the TOPARP-B study, which is another study of olaparib in metastatic CRPC, where there was an assessment of individual HRR mutations to determine which ones seemed most responsive to targeting with olaparib. As you can see in the right-hand side, BRCA2 seems to be one of the most highly responsive alterations identified when treated with olaparib, as are some of the RAD51 alterations, and some others may not be as responsive. So this is important to keep in mind as we're treating our patients in clinic. Importantly, BRCA2 is the most common HRR mutation that we will see in our patients with advanced prostate cancer, which is encouraging since this seems to be also the most responsive. The safety data is similar to that is seen with other PARP inhibitors, which is relatively tolerable, but sometimes does require dose interruptions and dose reductions, as well as certain specific side effects that we should be aware of include cytopenias, fatigue, and some GI distress. Triton-2, which is on the screen now, is a phase 2 study of rucaparib, which was studied in patients with metastatic CRPC who had HRR mutations, and all patients in this trial, unlike PROfound, had exposure to an AR-targeted agent and docetaxel chemotherapy. Here we can see that the patients were enrolled and treated in this single-arm study with rucaparib with primary endpoints here, including objective response rate. And here we can see that those patients treated with rucaparib had an objective response rate here of about 50%. And this was actually highly important, I think, when we think about patient responses. And when we look at waterfall plots specifically assessing the RECIST response in measurable disease on the left and PSA responses on the right among patients with BRCA1 and BRCA2 alterations, these were actually really nice responses to treatment with rucaparib as a single agent in addition to ADT. Here we can see the radiographic progression-free survival from the Triton-2 study as well, showing a median PFS of 9 months. The safety data actually quite similar, noting some fatigue, some cytopenias, as well as some very rare LFT abnormalities. And both rucaparib and olaparib have been approved by the FDA for treatment of these patients. Importantly, rucaparib is approved for patients with mCRPC who have BRCA1 and BRCA2 alterations after treatment with docetaxel chemotherapy and an AR-targeted agent. Olaparib is approved for patients with mCRPC who have any one of the number of HRR mutations listed there at the bottom of that box. Patients have to have had exposure to an AR-targeted agent and progression of disease, but they do not have to have prior exposure to docetaxel chemotherapy. It can be before or after docetaxel chemotherapy. There have been some really compelling new studies, and I think these are interesting and thought-provoking, though not necessarily changing practice at this time, looking at combinations between olaparib and abiraterone in this first study, but generally looking at PARP inhibitor combinations with AR-targeted agents. So here we can see PROPEL, which is a phase 3 trial looking at olaparib plus abiraterone versus abiraterone alone in patients with first-line mCRPC, and patients had to not have had prior exposure to abiraterone on enrollment. Patients were enrolled regardless of HRR status, so they could have alterations, but they didn't need them to get into the study. And again, treated with abiraterone with or without olaparib, and followed for a radiographic progression-free survival primary endpoint here. Here we can see that radiographic progression-free survival by both investigator assessment and blinded internal central review was prolonged with the treatment of abiraterone and olaparib versus abiraterone alone in this first-line mCRPC setting. And this, again, is an all-comers population not selected for HRR alteration status. Importantly, I would say, abiraterone, I just want to remind us, is an exceptionally active control arm. This is a standard of care. So it's interesting and important that we see this progression-free survival benefit against that standard strong control arm. Importantly here, we can see that the adverse events did not necessarily suggest a synergistic adverse event profile, but really expected adverse events for each of these agents on their own, and no increased risk of MDS or AML. We can see that here in another form, and as you can see in the slides that you have at home. Magnitude is another combination study looking at patients who were treated with niraparib plus abiraterone. This was an mCRPC population that was enrolled with a known HRR mutation status in 2 cohorts, HRR positive and HRR negative. Patients were randomized to treatment in the first line of mCRPC with abiraterone plus niraparib versus abiraterone alone. And importantly, the HRR negative or mutation negative cohort was stopped for futility early on. Patients in the HRR positive cohort were followed. And here we can see that biomarker positive cohort showing an improvement in radiographic progression-free survival with the combination of abiraterone and niraparib versus abiraterone alone. And that was even more pronounced among patients with BRCA1 or BRCA2 alterations. And we could see that, again, there was not a synergistic combination of these drugs in terms of adverse events, but really additive. The events that occurred as we would expect for single agent niraparib and single agent abiraterone. Immunotherapy is, of course, something that's very important in mCRPC. Sipuleucel-T, as we all know, has been around for a long time and the approval here was based on the IMPACT trial that showed an improvement in overall survival associated with the use of Sipuleucel-T in mCRPC versus placebo. And that may be more pronounced among patients who are Black Americans and also among patients who have a lower PSA than the median in this trial, at least, which was around 29. Importantly, other immunotherapy approaches have been investigated in mCRPC, and this is a really interesting study looking at patients who had progression on enzalutamide and were treated then with pembrolizumab and found that they had some additional activity there associated with that combination. Pembrolizumab is approved as a single agent, as we have heard earlier in this course, for patients who have MSI high status tumors who have mCRPC. It's also approved for patients with TMB that's greater than 10, and for patients who have germline alterations that are consistent, germline or somatic alterations, I should say, that are consistent with Lynch syndrome. Here we can see on the right some scans suggesting response from patients who were treated with pembrolizumab. And on the left, we can see how frequently we see MSI high status among patients with MCRPC. It's approximately 2 to 3% of patients with MCRPC. Importantly, we have to test for it in order to find it. And if we do test, we might find it in some of our patients, and they may have actually a fantastically powerful drug that has very few side effects. So important to test for this for our patients. Generally, how do we identify patients for any of these agents that I've talked about today? Well, we have to do germline and somatic testing. I already mentioned that among patients with metastatic prostate cancer, that's hormone sensitive and castration resistant, germline genetic testing is recommended by the NCCN and by the AUA. That's not based on age at diagnosis, and it's not based on family history. It is a blanket statement that should happen in all of our clinics. In addition to germline testing, we should do somatic testing on tumor tissue, either from a metastatic site or from the primary biopsy specimen or prostatectomy specimen, because what we can see in this chart or table is that half of the alterations that are going to be so important to our patients in terms of treatment, like BRCA2, are somatic mutations, and the other half are germline. So in order to understand all of the options for treatment for our patients, we need to do both germline and somatic testing. Here we can see the NCCN guidelines that make this recommendation. Again, this is for all patients with advanced prostate cancer. When they're metastatic, absolutely all of them. And when they're regional, those patients who have high risk disease, very high risk localized disease, and patients with lower risk disease, but who have a family history are recommended for testing. So in summary, PARP inhibitors, rucaparib and olaparib, are FDA approved for the treatment of patients with MCRPC and HRR or DDR mutations. Rucaparib is approved for patients with BRCA1 and BRCA2 alterations after an AR-targeted agent and taxane. And olaparib is approved for patients with any one of a number of those HRR mutations that I showed on the slide after progression of disease on an AR-targeted agent, regardless of taxane exposure. Zipiluce-LT remains an option for asymptomatic and minimally symptomatic patients without large visceral disease, and Black men and men with a lower PSA may have better responses to treatment. Pembrolizumab is FDA approved for men with an MSI high tumor, as well as patients with high TMB and patients who have those mutations that are consistent with Lynch syndrome. MSH2, MSH6 are examples. Guidelines suggest germline and tumor testing, so germline and somatic testing for patients with metastatic disease. DDR mutations and MSI high status are what we're looking for because it can give options for patients. Thank you.